Good morning, everyone. Today we will start with our case interpretation session, starting with this case of 38-year-old male patient presented with a neurological deficit. So just a second, let me remove these things. Okay. So brain MRI was ordered for him.
Coronal MRI flare.
Good.
Okay. You go to axial.
This is a warm-up film, so it's an easy case, not something.
Okay. Axial T2.
Okay, excellent. Good job. Tell me, what do you see as you move on? Say
Okay.
normal كذا, normal كذا, normal.
The ventricle and sulci appears to be a little bit dilated.
Mm-hmm.
There is tiny foci of high signal intensity within the white matter.
What are these foci of high signal intensity within the white matter? What do they call it?
But the age is not for ischemic white matter change.
So,
Yes.
so what do you call them? What are these?
Demyelination?
Do they appear like that? Demyelination?
No, not that.
Come on, a 38-year-old.
Vasculitis?
What kind of vascular?
Vasculitis.
Vasculitis. Wow, big jump to vasculitis. These are excellent, beautiful. These are vertical Rubin spaces, perivascular spaces. منو بيكم أخذ ما حد يمكن أخذ الكورس مال النيورو أناتومي مو صح؟ You should know that. We talked a lot about perivascular spaces. زين. Are they pathological? No, they are normal. So we disregard them. These are linear, thin. اي طبعا لانه اكزيال. اخذي كورونال وساجيتال راح تشوفينهم linear وكذا. And they have the CSF signal on all sequences. What is the fluid in the vertical Rubin spaces? يلا الاناتومي. هاي التعب كله هيك راح. What is the fluid that is seen in the غلط in the vertical Rubin spaces? It's not CSF. It's full of CSF signal, but it's not CSF. It's what? It's interstitial fluid. It's not CSF. Does subarachnoid hemorrhage go into the vertical Rubin spaces or not? Subarachnoid hemorrhage goes into the sulci and gyri and subarachnoid space, صح? So does it go into the vertical Rubin spaces or not? It does not, because it's not CSF, it's interstitial fluid. MCQ مال ترسيب. It's yeah, this is vertical Rubin. So what do we have here? Let's help you a little bit.
Okay. Contrast.
Give me a sec. Contrast for what? What is the images? Where are the images? Anything wrong? I don't know. Maybe something wrong with the. Come on. I got it. Just a second. Where is the axial T2? This is the axial T2. Now, just scroll and tell me if you see anything abnormal. By the way, it's big. Big, يعني مو not a spot. And please keep quiet. Let your friend focus and goes on.
Yes. And midbrain looks okay.
Okay, midbrain is normal.
Yes, hippocampus and medial temporal lobe looks normal.
Good.
The what carotid artery appear?
Wait. Is this normal?
Dilated third ventricle.
Dilated. Where is the third ventricle?
No. Sorry, this is.
So it's between the thalami. Is it dilated? The third ventricle?
Yes, dilated.
Eh? Any, maybe
Yeah.
mild. Okay, no problem. What else? Come on, are you kidding me?
Appear like cystic, yeah.
It's a lesion there. It's a
Yes.
big lesion.
Yes.
You can see all of this. It's a big lesion. Now, find it on other sequences and describe the signal intensity.
In T1 appear low signal intensity.
And T1 slow signal.
And T2 high signal. So it's
High signal intensity. CSF signal intensity.
Arachnoid cyst.
Arachnoid cyst. How do you be? Is this a common location for arachnoid cyst?
No.
It's not a common location. So what would you like to do? Well, let's say, what's your differential diagnosis other than arachnoid?
Epidermoid cyst.
Epidermoid is a possibility. What else?
Prosencephaly.
Porencephaly.
Yeah.
Porencephaly should be something congenital. Okay, I will accept it. What else? What about hydatid?
Yes, also.
It's also possible. What about cystic metastasis?
Yes.
صح?
Yes.
You have to mention all of these. So, how do we differentiate between all of these?
First, we do a flare to differentiate with epidermoid to arachnoid.
You do flare to differentiate epidermoid from arachnoid.
Yes.
Just please answer. So, see the flare, and wait a second. What epidermoid appears on flare, and what does?
On flare will be partial, not complete separation. Will be partial separation.
Okay.
Yes, but arachnoid will be CSF and complete separation.
Let's see. This is the flare. Partial or complete? Guys, just keep quiet, please.
Axial flare, we have it?
No. Where is the lesion here?
Here.
Is it partial or completely suppressed?
Partial.
So how you be sure of its?
How we sure we do any differentiation?
Guys, just please يعني I know تعرفوا من تقعد على الكرسي اقعد راويني عضلاتك يعني.
Also we do our IDC map and diffusion.
شوف الاي دي سي. What do you have here?
What about this is diffusion? What about IDC?
The one below it.
There is a restriction.
It's restricted on
Yes.
diffusion weighted image.
So it's not arachnoid.
So what is it?
Epidermoid.
This is an epidermoid cyst. Where is it located? Can you tell me the anatomical location? Of course, you won't see anatomy on ADC map.
Yes.
So go back to the T2 or T1, whatever you like, the axial, and try to locate the lesion. What would you write in your report?
It is in the aqueduct.
In the aqueduct. Okay, let's do another trick. Wait. Let's localize it in two planes. Now, where is it?
It's a quadrigeminal cistern.
Quadrigeminal plate cistern. Excellent.
Yes.
Beautiful. Thank you very much. So this is a 25-year-old male patient presented with long-standing knee swelling.
Long-standing. Axial T2 image MRI.
This is not T2. This is proton density,
T2
fat saturated. Good.
proton.
It's, to be precise, it's
Yes.
not T2. It's proton density. In the joints, you do proton density. It gives you better details. Yani that if you want perfect scientific answer, we say it's T2, but it's not. It's proton density.
وبعدين مش proton density.
يلا.
There is well-defined
Good.
well-defined lesion seen in between upper tibia and fibula, between upper tibia and fibula.
Between upper tibia and fibula. Yani, is it arising from the tibia or fibula or from the soft tissue?
It's mostly from tibia.
Not mostly.
It's
Tibia or fibula or soft tissue? Be specific.
Tibia.
Tibia. So there is a lesion arising from the tibia. Tamam.
It's of mixed density.
Mixed intensity. And is it of mixed intensity? What is this example? What's the sequence?
It's contrast.
So
it's enhancing.
What's the sequence? T1, T2 proton density.
T1.
So it's T1 fat saturated. Yes. So you skipped all the T1 and T2 and fat saturated and went directly to the contrast, which is a fatal mistake in the exam. Start. Wait. Start from the beginning. Let's see here. This is the proton density, or T2, let's say. And this is the T1, and this is the T2. Yeah. Start with the, just a second. Yeah. Stop here. Describe what you see.
Well-defined hyper-intense
T2 hyperintense, you have to say.
hyper-intense signal lesion seen in upper tibia, occupying the metaphysis and epiphysis. بس خليني اشوف اذا مثل cortical destruction or not.
Sure. Just lift it a little bit up, okay? This is a real T2. This is a T2.
Yes.
حقيقي يعني.
It's a hypo in T2. معناته it's not fluid.
Yeah.
It's a hyper in T1.
T1 it's hyper? This is hyper?
يعني.
This is isointense to the muscle.
To the muscle. And in proton density.
No, this is localizer.
It's hyper intensity in proton. يعني mostly it goes with the lipid content.
Okay.
Lipid content lesion. There is مثلا bone marrow edema.
Some surrounding bone marrow edema. So it's wait. Okay. It's isointense on T1 to the muscle.
Yes, to the muscle.
And hypointense on T2. And hyperintense on fat saturated images. Okay? صح ولا لا?
Yes.
And all of this leads to lipid content. Lipid containing lesion will appear what on hypo on
high
T1?
in T1. Low in T2. High in T2 بس شوية يعني أقل.
Okay, so it's hyper on T1 and less hyper on T2. Is this hyper on T1 or less hyper on T2?
لا hypo هذا hypo in T2.
Does it suppress on fat saturated image? So why you see lipid content?
It's enhancing.
هسه في enhancement. There is a first when you see a bone tumor.
Yes.
It's location.
Yes.
Where is it located?
Located in upper tibia. Metaphysis reaching the epiphysis.
What else?
Not causing cortical destruction.
Not causing cortical destruction. So it's expansile or not expansile?
Expansile.
Expansile. Most important thing when you see a lesion in the upper or the end of the bone is to say what?
Location, the cortex or medulla.
هسه قلنا cortex.
إيه.
What else? Very important thing to say for the surgeon. You have to report it. Is it extending to the articular surface or not? It's a big difference.
Not reaching out.
Come on, girl.
حتى إيه هاتين
This is the articular surface. This is the.
ما بسوي destruction دكتور.
I didn't say destructing the articular surface or not. I said extending to the articular.
yes.
So when he
Muscle
removes the
specific.
lesion, will he have to support the articular surface or not?
تمام.
This is the articular surface, and it's just at the end of the articular surface is involved.
Yes.
So it is extending to the articular surface. Crossing the growth plate, the physial
Not
line.
crossing. إيه ما مسوي crossing.
When the physial line or
Wow.
growth plate? This is the okay, ماشي. This is the this is the growth crossing or not?
Yeah, crossing.
It's crossing.
Yeah.
Okay,
Yeah.
so we have well-defined lesion crossing the physial line or growth
Reaching
plate
the
line,
articular surface.
eccentric, cortical,
Expansile.
expansile, T1 iso-intense, T2 hypo-intense, hyper-intense on saturated image, reaching the articular surface. Now you give contrast. Showing what on contrast?
أبد enhancement.
Showing يعني you can't wait. This is the post contrast. Show me the contrast. Okay. So showing avid heterogeneous post contrast enhancement. Your diagnosis.
hemangioma يعني.
Possible hemangioma. ماشي. What else? خلينا نسوي differential أحسن. Let's make it
Hemangioma.
differential diagnosis.
Metastasis.
Metastasis. Good. What else? Guys.
Bone.
Quiet, please.
Bone tumor يعني إذا.
Okay.
Expansile.
Wow, bone tumor.
expansile bone tumor مثلا هذول بس الانيوريزمال بونز هذول لا ما بيسوون ليفر.
Aneurysmal post is a possible differential diagnosis. What else? What's lesion that happens in 25-year-old patient, that's adult patient, at the end of the bone, crosses the growth plate, reaching the articular surface? One of two. If it's reaching articular surface or it's not reaching the articular surface. If they're not reaching the articular surface, it's what? It's what? Aneurysmal bone cyst. If it's reaching the articular surface, it's what?
جان.
You agree or you just?
لا تيومر ما قاريته على.
I don't care what you read or what you don't read. You have to tell me. I don't. It's not my job to know what you read. This is a typical giant cell tumor. Giant cell tumor. Sometimes there is an ABC, or aneurysmal bone cyst arising within the giant cell tumor. So you can have both in one lesion. You can have. This is not. Okay? Second. Third. Giant cell tumor, it's a benign or malignant lesion? Yeah, that's for all of you. Excellent. It's locally aggressive. It's benign, but locally aggressive. So the treatment must be really aggressive. They have to remove everything. What do you mean by locally aggressive? What does that mean? غلط. 10% of giant cell tumor presents with local metastasis, with distant metastasis. You can have giant cell tumor with lung metastasis in about 10. It's rare, 10%, not much, but again, it can present with metastasis. Be careful. MCQ, this is a big MCQ. Sorry?
This means causing destruction of articular surface?
Cause destruction of articular surface and extending to the surrounding tissue, and most importantly, very high recurrence rate. They go in, they remove it, and in fact, to to give you more feedback on this patient, around 2 weeks ago, he returned back. He was completely curated with bone grafting and full recurrence. The tumor is just like here. It's like the surgeon never touched it. My knowing that the surgeon curated the whole thing, did a bone graft, and I don't know what, and he returned back with full recurrence. Just the tumor returned to the same size, like it's never touched.
هذا يسمونه شنو هسه؟
They remove the whole thing again and again and again and so on. Okay, so it can present with distant metastasis, although it's a benign tumor.
Distant.
You have to think of it. I don't know how. There.
The content of not because it's still
The content I would not comment on so much because on T1 it's not. There are no foci of T1 hyperintensity.
maybe acute bleeding.
Sure, according to the stage of the blood, but I think it's just a soft tissue mass, not no cystic component to comment on. Okay, and all ABC, all giant cell tumor can have ABC within it, so be careful of that because it will bleed if you biopsy it. Okay, thank you. Sorry. Within نفس giant cell نص يطلع inside of it the ABC you have. Okay. Hello. So this is a 9-year-old. Don't touch anything. Okay, just focus with me here. A 9-year-old male patient presented with backache, long-standing, generalized ill health. I don't know, pallor, things like that. So an X-ray was ordered for him. Okay. So tell me, what do you see? Dorsolaminal X-ray.
Decrease height of the lower lumbar is H-shaped vertebral line.
Here. This is an X-ray AP view of the dorsolumbar spine showing of a 9-year-old or of a child, skeletally immature, whatever you like, showing.
Can you make it on the lateral?
Yeah, sure.
From L1 to L4, showing decreased height. صار مثل H-shaped vertebra.
Just a second. Sorry? H-shaped vertebra. Good. So we have loss of height of multiple lumbar vertebrae.
Yes.
Okay? With H-shaped vertebra. Your differential diagnosis of H-shaped vertebra.
Hemolytic process.
Hemolytic process. Good. Like what?
Sickle cell disease and others.
Sickle cell disease first. And others. What others? Like what?
Thalassemia.
Thalassemia might cause. And spherocytosis even might cause. Okay? Basically all kinds of hemolytic anemia. So, MRI was ordered for this case to know the cause of his H-shaped vertebra. And now you have this MRI. You can start, just lift it up a little bit. Okay. So what do you see?
Okay, sagittal T2 sequence.
This is a sagittal T2-weighted MRI showing.
Generalized decrease the signal intensity of all of the vertebra.
Beautiful, love it. Continue. Mark generalized decrease signal intensity of what?
Of the vertebral bodies.
All the bone.
All the bone.
All the bones. So of bone marrow.
Bone marrow.
Okay, generalized loss of signal or decreased signal of bone marrow, seen involving all visualized bones. What else?
There's high signal intensity.
This is the disc.
This
Yes, yeah. The discs. He's a child, so the discs are fully hydrated. Now let's see. Let's wait on T1. What do you see on T1? Is this normal signal intensity of the vertebrae on T1?
no, again decreased.
Again decreased.
Yes.
So indicate why is that decreased bone marrow signal intensity on T1 and T2
Due to
due to
high will be extramedullary hematopoiesis and
extramedullary hematopoiesis. Well, in fact, we're talking about the medulla. It's
The
not
medulla.
extramedullary.
yes.
So what's going on? It's increased bone marrow activity
Yes.
to compensate for
The anemia.
hemolytic anemia, for anemic process that causes rapid loss of blood cells. So the bone marrow works like overtime,
Yes.
to compensate. And this results in marked loss of what?
Signal.
Of vertebral height on multiple levels, okay? Causing this deformity, loss of lumbar lordosis. You can see it's kyphosis here, okay? So let's see the coronal image. Just as this is a survey. Let's go to the axial. No, wait. Let's see the axial. Maybe we see something here or there. I don't know. Is there anything like, I don't know, significant? Continue. Okay, you will have nothing that catches the eye, we can say. So, do we have the rest of the spine? What else? Let's see this one. This is better, a little bit better, maybe. Then, can you tell me if there's anything significant in the axial images? Or yes, let's go to the coronal.
There is evidence of hepatosplenic again.
So, your diagnosis,
Hemolytic anemia, Tanzania.
like what?
Like a special anemia.
Sickle cell. Does sickle cell cause splenomegaly?
No.
What does sickle cell cause?
Autosplenectomy.
Cause autosplenectomy. You have loss of spleen.
Yeah.
What kind of anemia causes splenomegaly?
Thalassemia.
Excellent. Thalassemia. So when you have a case of thalassemia with splenomegaly and generalized bone marrow signal loss, you look for what? What else you look for? Anybody? When you have case of thalassemia with splenomegaly, bone marrow signal loss, blah, 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 what do you look for on the lumbar or dorsolumbar spine? Now you look for extramedullary hematopoiesis, which manifests as what? Soft tissue masses around the vertebral bodies. Can you see any here? I don't know. I don't remember the case, to be honest. Do we see anything that might suggest extramedullary hematopoiesis? Well, I don't think so. It's not perfectly. خلينا نشوف والله axial. Let's go to the axial. Will be even easier, I think, to look for masses not clearly evident. And you can, from the axial, you can see the enlarged spleen. Just see the spleen, how big it is. So this is a case of what? Thalassemia. If it's sickle cell, might present with splenomegaly in the early stage, and then it will progress to autosplenectomy. You see the spleen as what? What would you say the spleen will be what in autosplenectomy?
Will be shrunken.
Will be shrunken and
Small.
and calcified. You'll see calcified spleen. Okay? Thank you very much.
Thank you.
See you next week.